Thank you for joining. My name is Kerry Page and I'm the Programme Manager for Rethinking Pain, a community sector-led and based chronic pain service. Rethinking Pain aims to transform pain support across Bradford District and Craven by providing adults with a joined-up, accessible pain pathway that connects their clinical care with person-centred community-based support. My personal experiences in development, implementation and evaluation of innovative and importantly evidence-based health programmes. But my angle today is a little bit different and I won't be talking to you specifically about opioids. Rather, I'm going to talk about how connecting our efforts to reduce opioid and strong pain relief medication use can be improved by including effective community sector collaboration and engagement as part of any project plan, ethos or work that you're doing. Responsibility and outcomes for Rethinking Pain lay with their lead partner, a health and wellbeing charity called Keithley Healthy Living in Bradford. They are part of the VCS, the Voluntary and Community Sector, and that's along with clinical partners, 12 primary care networks, the wider VCS and our commissioners. Together we all make up the Rethinking Pain team. The service was commissioned in November 22 by the ICB, Bradford District Health and Care Partnership, under their guiding principle to act as one. It was informed by the NHS Long-Term Plan 2019 and it fits in line with a lot of the King's Fund and others' reports and calls to action on the importance of integration of care. While there are pockets of practice in integration of pain services across the country and some great work going on, we believe we're the first service to implement an integrated pain pathway like this one. In the next 10 minutes, I'll cover our aims. I'll give you a snapshot of how we deliver the service and its core components, explain the educational aspects for patients, GPs and allied healthcare professionals, and show you some examples of recent quantitative outcomes. I'll also signpost you to some qualitative resource and tell you about some papers that we're publishing. Importantly, I'll also advocate for greater community sector engagement and collaboration, joint commissioning, and our thinking to be around sustainable investment. Firstly, I'll start with briefly talking you through the Rethinking Pain service offer and the how of what we do. We're a small multidisciplinary team of about 10 full-time equivalents. That includes our GPs, Asim and Shazad are two of those, health coaches, health psychologists, peer support facilitators, and education designers and delivery leads. In terms of coming into service, prior to referral, we've developed a bank of tools for primary care healthcare professionals to use with patients first. It's really important because this ensures that as much as possible has been done with the patient in practice and that people referred to us will benefit from this kind of support. Part of our triage into service includes expectation that there's been a medication conversation and review. So just quickly to let you know who we're looking after in our service, adults are referred by their GPs and healthcare professionals, MSK services by System 1. We'd start work with them between 10 and 20 working days. The average time for someone in service is 8 to 12 months. And individual cases can be reviewed at our twice monthly MDT meetings. The only exclusion to be coming into service is anyone still undergoing medical investigation for their pain or an operation, unstable SMI, and those who, after the conversation with their GP, reject the proposal of taking a degree of ownership for their pain management, or who are really not open to the concept of at least adopting some individualised lifestyle and behaviour change. At entry to the service, our coaches conduct an initial pain assessment. We use the EQ5D for this, alongside some quality of life measures. The next steps, light touch support, pain-related information and resource. For example, our joint decision-making tool, pain support plan, and our pain flare-up plan, and then the signposting to local help. To progress through the service, people need to attend online or in person our Understanding Pain adult education workshop. We don't use the word education with our service users. Understanding Pain is the foundation stone of our workshop interactions. It covers what pain is, how the body responds, and then brings into the discussion pain medication. This is a really important turning point in the whole conversation we're having, because then we're going to go and talk to them about other things they might do to manage pain. So we talk about when medications can be helpful, how their effect may lessen or cease, and possible side effects. This conversation in the session can be slightly contentious at times, but really it mostly generates useful group discussion. It can also be quite emotive, especially for many people whose crutch and their only way of getting through the day is opioids or strong pain relief medications and frequent contacts with their GP or healthcare professional. We also see people in the session have a penny drop moment and start to consider that their medications might not be their only route to pain management. Participants have conversations in that session they might not previously have with a family member or even a medical professional. They might be talking about how many pills they take, how long they've been on them, worries about side effects, and they start to also consider the possibility of some of how they're feeling. For example, heightened anxiety, nausea, and loss of concentration could be related to medications they're taking. And then if people want to discuss their medication more, our coaches signpost them back to their GP to have that conversation. Briefly then, after understanding pain, the person is given a dedicated pain-trained health coach who'll signpost them into pain-supportive community-based activities, importantly, that are very tailored and meet their individual needs, preferences and circumstances. An example might be somebody might be having a crisis intervention. They might need help with housing, but also at the same time, they might be able to go into a Tai Chi class, receive some mental health support, attend a singing club, and a lot of the time go to social groups, because we handhold into those for all the people who are quite lonely and isolated. We've got loads of case studies demonstrating pain-related outcomes from this kind of holistic, clinically joined up support. The coaches encourage the person to use tools and coping strategies to progress and achieve goals. A really surprising outcome, and there's a great slide around opioid use and exercise that I haven't shared, but I wish I had now, is that the high percentage of people the coaches get into gentle movement, exercise classes, and also into relaxation techniques, and how they report that, what that does for their experience of pain and improved mental health. People frequently tell our coaches that due to getting involved in those two practices, they've reduced or stopped using pain relief medications safely. At this point, people can access stage 2 of the service, which is 10 adult education workshops. The topics are driven by people in our service, and they include sleep, acceptance, telling my story, creative therapy, diet and pain. Tier 3 of the service includes talking therapy, including CBT and ACT. I've just put some examples there of some of the resource we use. And I do not want that to play. But I just wanted to talk a little bit about Bradford, and some of this is really transferable and scalable to the areas you're in. It's a diverse community, and our service really prepared itself to deliver accessibly and inclusively by applying best practice methods. But even so, cultural adaptation of our work has been a learning curve, and we're still applying and adapting that learning. In terms of meeting diverse communities' needs, this is where you find partnership with the community sector is absolutely vital to achieving what you want to achieve. The VCS are adept at quickly adapting delivery to meet place-based needs. They're able to reach right into communities, and they're able to bring something to the table that some others cannot at a relatively low cost. So I just want to say that 25% of Bradford's population identify as Pakistani. I wanted to explain that some of our cultural adaptation then has been interesting, because we, for example, thought we might deliver in Urdu, Punjabi and Patwari. What we've learned is that actually this becomes a combination of these languages when we deliver, with some trusted English words thrown in. And our team and people in our service now sort of respectfully call this delivering in Bradfordian. We've learned as well that some of the key pain messaging we try to deliver, if it doesn't meet people's beliefs or sit with their spirituality, for example, when we're delivering sessions in relation to teachings of Islam, that pain messaging or medication messaging isn't landing how we wanted it to, and we're doing some research on this. I'm going to quickly and tell you that I want you to have a look at this slide. This is really recent data. Providing an evidence-based and robust evaluation in our service is crucial, and it's especially important when you're advocating for change and leadership in how healthcare services can be integrated, commissioned and delivered. So our data is looked at on System 1 by the ICB and analysed, and we also have our service outputs are evaluated by Leeds Beckett University's Pain and Analgesics team. We share our learning locally, regionally and nationally, but just look at this data. This is recent ICB data, and it demonstrates savings to the NHS against only 5 parameters from a cohort of 937 patients. Their data was analysed for the year before coming into service and a year after being with Rethinking Pain service from 23 to 24. So keep in mind that while you can see reductions, for example, in GP appointments of 6%, a significant result in itself, this is even more pronounced when there's also an increase in GP appointments in the general Bradford population of 7%. Similarly, where there was a 15% reduction in AM presentation by the cohort with Rethinking Pain for that year, the general Bradford population presentation increased by 6%. None of that's kind of been factored into the financial savings shown. And while this is really not scientific, remember that this saving here of only 200,000 is only across 5 parameters for 937 people in primary care. So just imagine then a projection of what could happen if pain pathways actively included the VCF and self-management approaches, and these were adopted across millions of adults in this country living with pain. And then look at the social value on return of investment related to the quality of life measures, which for people we work with are the important things, not the NHS savings. It's things like sleep and getting back to work. My last slide signposts you to the recent perspective publications that we've written with Leeds Beckett University and a fascinating pain concern Airing Pain podcast. And I've highlighted 2 of 5 papers and reports we're intending to share from May to July 25. Thank you very much for listening.